Yes.
Yes, sir.
All right, excellent. Let's go ahead and get started. So I hope you had a great spring break and got to come back with the IPC class. I think the thing I really like about this case is that it was a real deal case that happened right here in Savannah, right as we were putting this course together. And there's probably a lot of different things we can talk about. The key that I think just looking at, how students did on the practical and just kind of helping you going forward, is just to be really organized in your mind and how you're presenting things so that you don't leave anything out. Don't leave anything out. And I think that's going to help you going forward. For example, whenever you're taking an organized approach on the student instructions that we had for the practical, as far as assessing a problem, working through those over and over again to get practice in doing that. That's going to help you long term. As identifying a drug-related problem, assessing that problem, right? Explaining that problem, like what the explanation is of that problem, developing a plan, having rationale for that plan, and then ultimately, from a monitoring standpoint, identify the safety and efficacy parameters associated with that monitoring. If you do that over and over again, I know that it's stressful within the practical. You kind of forget some of those things, and that's why it's important to be organized from the get-go and just kind of practice those things leading up to what's going to be our second practical. So, with that, we've got our case going here. Let's see here. Old Henry. So, with Henry Lawrence, he's got quite a few problems, right? That we've got to go over. Not the most complicated person in the world, but not the least complicated either. Kind of in the middle. That's what I tried to go after. So he's a 71-year-old male. He comes to the med-surg unit of the hospital directly from Highlands and long-term care facility for the evaluation and care of a skin soft tissue infection, essentially. He has a history of Parkinson's disease. He's got culture positive, and he needs full assessment of his problems. So you go in here. Let's see here. Try a new session here. So looking at his overall problems, let me take a volunteer from here in Savannah. What was the primary problem that you saw with Mr. Lawrence? Yes, Smith.
His cellulitis.
His cellulitis, right? So that would be his primary problem, okay? How would you describe his cellulitis?
It was MRSA.
Okay, so that's the organism, right? So we've got MRSA, right? So where was the cellulitis? Did you see where it was located?
Left lower extremity. Sometimes it says right
It's on the lower extremities.
Right, okay, so lower extremity cellulitis. Right, so that's definitely identifying the primary problem, right? He's here. Ultimately, anytime you're reviewing a case, for this class and then going forward into rotations, really the first question I ask on any patient I'm looking at is, why are they here? Why would you subject yourself to coming to a hospital, right? There's got to be, and the chief complaint will give a lot of help to that, but knowing why this person was either transferred to the hospital, and patients can come from a lot of different areas to the hospital. Some of them come from home. He came from essentially an extended care center, a nursing home, another hospital. Here in Savannah, we get a lot of transfers from a lot of regional hospitals where maybe they don't have the ability to take care of that patient for what they need. Maybe they need a cath lab, right? Maybe they're having an acute MI, and they need that sort of resource that you can't have at the middle of Georgia Medical Center in the middle of nowhere. Okay, so why are they here? Where are they coming from? Those are two things that really are crucial, and are things that when I'm having my students present to me on rotation, they have to tell me those things in the beginning, okay? So that gives me an idea of they understand the big picture. One of the hardest things as a student is understanding the minute details, but really putting it into a whole package of the big picture. Would y'all agree with that? Okay? And that's what this is hopefully trying to do. I felt a lot better after the practical personally. I know some of y'all don't feel that great at times, but I actually felt better compared to a year ago. So I think we're making progress in that, identifying the problem. Okay? So cellulitis of the lower extremity. How about somebody in Augusta? So how would you assess that problem and give an explanation for that? And maybe even a primary plan. I can call on group. How about group 20? Temple, Katie, Alicia, Summer, who else? What was y'all's plan for, did y'all have this as your primary problem?
Yes, we did.
Who's this? Who's speaking?
Alicia.
Hey, Alicia. All right. So, what was the issue with the cellulitis? What was your plan for it?
We did vancomycin 1,000 milligrams every 12 hours.
Okay. The vancomycin
After the
1,000.
IND.
Oh, okay, good, good. Okay, so post IND, right? How often? 1 gram, how often?
Every 12 hours.
Okay, did you do any calculations for that? How did you come up with that?
We did 15 to 20 milligrams per kilogram.
Okay, and good. So 15 mg per kg, IV Q12. Okay, good. Post IND. Why did you choose that? What was your rationale?
Because of the MRSA.
Because of the MRSA, okay? And what else? Why couldn't I have chosen something like Bactrim or Doxy? Why Bank?
I mean, if they're in the hospital, just give them back.
Because that's
Susceptible to it? It was, yeah.
By the
IV
way, I'm
Bactrim
not trying to
requires a
tempt
lot of
you.
fluid.
Just trying to get questions.
IV Bactrim requires
Okay.
like a large
So
volume
yeah,
of
so
fluid.
the Bank is a classic drug for MRSA,
It's like hard to.
cellulitis, abscess, I got it. So what would be an advantage of it over say Doxy or Bactrim?
Give me an amber.
One or the other.
less fluid in the IV bag.
Okay, yep, so maybe some less fluid. Where is he being treated at? In the hospital, right? He's an inpatient.
Yes.
There you go. Right. So, because there's going to be a twist in this case that comes later. Okay? To kind of get you thinking about transitions of care. So, as an inpatient, you got to use Bank. That makes sense. Like, there's a drug like Bactrim or Doxy or Clinda. Clinda we can use IV in the hospital primarily for kids. But for adults that are admitted with cellulitis, generally they're going to be put on vancomycin up front. Okay? This kind of confirms. More than likely, he would have been on this from the get-go. Down in the ED, they put him on, the old joke, everybody gets vancomycin, right? Whether you need it or not. That was supposed to be funny, but obviously not. And Fisher's calling. Can't answer that. All right, so within that, when you go in, and what's interesting is you read the H&P, right? You want to find out what's wrong with the patient. You start reading the notes, right? Hospitals, H&P, maybe one day. And, so you start looking at it, you read a little bit more, and you try to get a sense for why, what's driving that, what's here. What's interesting to me is reading this, you knew the primary problem, right? When you go to meds, what did you not see?
Antibiotic.
You didn't see an antibiotic, did you? I see this happen at least monthly, where in the notes they talk about what to do, but then nobody executes the order. So in actuality, you know, this person's been here a little bit, they've not really gotten any antibiotics. Is that a problem? Huge problem, right? So for pharmacists, one of the things we do is never assume that a person has gotten their therapy, because in all likelihood, they may not have gotten their therapy. So if you scroll through all their meds, you're not going to find any antibiotics. So their primary problem is really untreated at this point. First case I ever had at Candler that I intervened on was a septic joint infection. And ID in her note was saying, start vancomycin. The hospitalist was saying, continue vancomycin. And the patient wasn't getting vancomycin. So it was all a pipe dream, okay? So continuity of care and ensuring, we're kind of like evaluating, especially in a community hospital, community health setting, they may have 5 or 6 consultants on at one time. And so knowing what the other's doing, and you really are a fail-safe for that patient to make sure that they're getting appropriate therapy. So the whole point of this happened on this patient that I had, they didn't get anything. So we had to intervene and actually say, hey, I see, this is kind of, how would you handle that conversation, by the way? How about group 19, Ben, Sydney, Nikki, Brielle, and Aubrey? How would y'all handle that situation when you call the provider?
If they weren't getting the bank,
Mm-hmm.
just say, I recommend they need to be on the medicine. Yeah, but they would provide the one bank that like they weren't actually getting the bank, just said in their notes they were getting it, they weren't actually getting it.
I would just say I looked at the ministry and I said,
Team 19, y'all still around?
yeah, we're just deciding on how to word this.
Okay, all right. Because it's not easy, right? I mean, one way to not do it would probably be like, hey, doofus, do you want your patient to get any antibiotics or not? That's probably not a good idea. So how could you handle it?
You could say that you were reading through the provider's notes and you agree with his assessment that the patient needed to be on vancomycin, but when you looked in the medication administration history, it wasn't there, so you just wanted to make sure that it was added on the next day.
Yeah, exactly, right? To say, hey, I'm reading through, you know, like a lot of times I'll start this, you know, call and say, hey, I'm monitoring the patients on this floor, happen to run across your note, saw the patient was supposed to be on bank, but I don't see it was ever started. Do you want me to start it for you? And a lot of times as a pharmacist here, we can enter the order for them, but some providers may elect to just do it themselves. Okay, it just depends on the provider. But yeah, you know, the good thing is an intervention like that builds you a lot of credibility. You're taking care of the patient. I had a similar case recently where somebody was, they had a mitral valve that they were being anticoagulated for, and their INR was nothing, like 1.0, so they've been off coumadin for 3 weeks. And I went and looked, and they had started their home dose of coumadin back, they thought, because actually they started 10 milligrams a day, but the patient was alternating 15 with 20. And a person like that, they have to be on a heparin drip because they're at high risk for a clot. So what would have happened if we had they would have been on days of coumadin with no effect, and then they're staying in the hospital days and days, and then what's going to happen? We're going to give them a pre-infection, right? Have a urinary tract infection, have some sort of complication, right? So reconciliation, not assuming, those are really important things to do. So I agree, the vancomycin is a good recommendation. How about one of our Athens teams? How about Group 2? Group 2 in Athens? What would be some kind of monitoring for the bank? How would you monitor that? Or if you chose something different, I want to hear it.
We also chose bank, and we would need to monitor the trough levels.
Okay, all right. So you always want to think about toxicity and effectiveness, right? So you say trough levels, what's your goal?
15 to 20.
10 to 15, exactly. Good. Have fun with it. Remember, 15 to 20 is invasive, like bone and joint, meningitis, pneumonia, not just skin soft tissue. That's going to be more 10 to 15 micrograms per ml. Okay? The trough level typically before, when you want to check it? Fourth? Third? We had a magic level today, so Jasline's my academia resident with me. She had an interesting weekend. She took a bank trough and it was 89. Is that true, Jasline? It is, right? And yeah, they didn't get any bank after transfer from another hospital. It was 89. Then we checked it again, and what was it? 16. Magic. Magic. So, listen, very important. Don't be a slave to the lab. If the lab looks wrong, re-verify it. Re-verify it. So if somebody's trough level comes back some crazy number, we have an expression, right? We try not to do bank levels on weekends. I don't. Because the weekends, typically labs get crazy. And they get inaccurate. Okay? So a good rule of thumb is if you're doing serum concentration monitoring, typically I do it during the week. There are times you can't avoid it. You're going to do it on the weekend. But typically before the fourth overall dose. Okay? All right, what else would you be monitoring? How about here in Savannah, group 24?
We want to make sure the infusion rate is good enough so they're not having red man syndrome.
Okay, good. So red man syndrome, good. How about group 25? Yeah, serum creatinine, right? You're worried about nephrotoxicity, right? Good. So you're monitoring serum creatinine, and it typically is going to be a slow trend upward, right? You're not looking for a bump like day 2, but you're definitely looking for something, day 4, 5, 6, right? Anything especially greater than or equal to 5 days. That's where we start to see a lot of the toxicity build up. Okay? Good. How about effectiveness squads? What are we looking at? How about group 26? So trough levels, okay. What else? Yeah, exactly. Like resolution of symptoms. So when you got an abscess that's been drained, right? Essentially what you're looking for is you want to see decreased what? Erythema, right? Drainage, right? You're trying to see that resolving, and sometimes that takes a couple of days, but in general, as long as they've had good source control, should get better a little bit each day. A little bit each day. It's not going to be a miraculous thing, but it should get better a little bit each day. I'll take this font down a little bit. All right, so I think we all agree the primary problem. So the primary problem wasn't even being treated in this patient. Okay? All right, we'll try that one, see how it goes. Okay? All right, how about a second problem? How about Albany? Albany, love it. How about group 21? Brooke, Marcus, Cassandra, and Cameron. What was your second problem?
So the drug-drug interactions. So specifically QTC prolongation with Seroquel and other
Okay.
meds.
QTC prolongation. Okay, and you said with, say that again?
Seroquel.
Okay. All right, let me ask you a question. Who was that, by the way?
Cameron.
Marcus? Cameron? Cameron, you there?
Yes, sir.
Okay. Don't be shy, man. We're having fun today. All right? All right, Cameron, do you have any evidence that their QTC is prolonged?
I mean, I didn't see any.
Okay. Did anybody find anything that QTC was prolonged? I didn't think so. I didn't think so, but let me ask you a question. So Cameron, you're on the right track, okay? How would you best, so you're concerned because they're on Seroquel, right? And you know Seroquel, being an atypical antipsychotic, prolonged QT. Let me tell you something, prolonged QT, you will run across it over and over, I mean, on that drug interaction screen, whether you're at, in a community pharmacy or the infant, I mean, it's just relentless. It's like the post office, right? It comes every day except even Sunday, okay? So how do you deal with that? Because you're going to get that question all the time, right? So how do you deal with the concern about QT prolongation? Because I agree, I'm concerned. I don't have any evidence that it's a problem right now. Okay? So what would be some ways we could evaluate that? We'll work through it together. How about group 22? Did y'all have QT as a problem?
We were concerned about the QTC prolongation, but it wasn't our second problem. In order to address the QTC prolongation, we would need an EKG to see if it's present.
Yeah, baby. All right. Show me the money, right? Show me the money. The EKG, right? Because if you're really concerned, because I will tell you, people are on Seroquel all the time in the hospital. And I'm not getting an EKG on every patient, okay? But there's something about Mr. Lawrence that makes me very concerned about the QT med he's on.
He has AFib.
Can anybody tell me what it is? That's really the core
He has
problem for
AFib?
him. Say it again?
He has AFib.
Okay, he does have AFib. Yep, that's part of it.
His hypokalemia.
Ah, there we go, baby. Now we're getting somewhere. Hypokalemia.
Oh, you're tired. I
So
get like that.
this gets back to how do you assess QT prolongation potential within drugs? Let me just give it to you straight. Drugs by themselves almost never prolong QT to the point. Because why do we care about QT? Some. You right, Savannah? Why do we care about QT prolongation? Torsade plomb, right? The French arrhythmia.
What did he say?
Just kidding, I don't know what it is. But, and that kills people, right? It's ventricular arrhythmia. I've seen it twice in my life.
That made me feel better.
One was in a patient that had such profound hypokalemia and hypomagnesemia from cisplatin chemo patient. They came in, their mag was 0.5. And their K was like 2.5. Right? You can't have any electrical potential in your heart if your electrolytes are that low. Right. So hypokalemia, right? So what's our potassium in our patient here? 3.1, right? Which for some, it's definitely low. you know, it's not 2.5, but it's 3.1, it's low. But let's start adding up his QT med, shall we? So his his secondary problem is going to be hypokalemia, okay? An assessment of that, right, is it's low. It is low, right? So, why is this a major issue, right? Let's start adding up his QT med, shall we? So we got Seroquel. What else? Any others? Amiodarone, baby. Oh, I love amio. Love it. Lexapro. What else? Donepezil? Maybe a little bit. Trazodone. Right? He's got quite a few of them. Zofran. Zofran.
Just take them off.
Now, key point with Zofran. PRN. So how do you know if they're getting Zofran or not? Sounds simple, doesn't it? But I've learned never to assume. So what would you do? Because your preceptor is going to go, okay, I agree, you got Seroquel, amiodarone, Lexapro, Trazodone, Zofran. How do you know about the Zofran? Mary Savannah. Yeah, Kelly.
You can go like in their med history and look specifically at the Zofran, see if they've gotten it or not.
Yeah, go to the MAR. Go to the source, right? You go to the MAR, and a lot of times they'll have the times where it could be given, and you want to see, are you getting it or not? If they're getting hammered like over and over again with Zofran, that's a problem. Problem for a number of reasons. One, why are they continually needing Zofran? Should we not put them on something scheduled? Nausea and vomiting is kind of this, it's on every order set in the hospital. Everybody has a checkbox here, take some Zofran. Sure. Right? Even whether you're nauseated or not, we're going to put it on your profile, and then you kind of get added to over and over again. Okay? So, QT med, Seroquel, amiodarone, Lexapro, Trazodone, Zofran, right? Is that a recipe for a problem? Yeah, the more drugs you add on, person's already got atrial fibrillation, and now their potassium is 3.1. Okay? So somebody said, right, get an EKG. Get an EKG. I would say the assessment is low. As far as the preliminary plan, what else? So I agree, EKG, good idea. What else? EKG can be done in like 5 minutes. Okay, that's going to be something that's very fast. What else needs to happen?
You could see if the patient truly needs like the Lexapro or the Trazodone in DC, if they don't have an indication for it, to decrease the amount of drugs that have that potential problem.
Yeah, I like it. Okay, reassess. QT, prolonging meds. Yeah, now here's the problem,
I
right?
thought I was done.
All these are neuro meds, but now amio, I mean, what's the half-life of amiodarone? Pharmacy school, right? I'm just kidding, it's 60 days, okay? 60 days, so if you stop amiodarone and somebody's been on it, it's gonna take 6 months to really get out of your system, sometimes as much as a year. That's why monitoring is so important with amiodarone, because you gotta catch a problem early. Because if you don't, not going anywhere for a while. Okay? But the neuromed, what's the particular, who was that said that, by the way? Thank you for answering. Who was that? Oh, come on. Oh, so who brought up the fact maybe we reassess the med? Oh, it was you, Wes. I thought it was somebody on a different campus. I'm sorry, Wes. Oh, it's a different campus. All right, Wes, what's the with, you reassess these, Seroquel, Lexapro, Trazodone. You say, all right, I'm going to stop some of these. What's the potential harm?
If they truly do need those meds, then, I mean, that would be good if,
Yeah, what happens when you stop any med in the brain abruptly? You can get a discontinuation reaction, right? So if somebody's on, Lexapro, you can get a discontinuation syndrome where they start getting anxious, sweating, kind of acting crazy, right? Trazodone, same thing. Seroquel, a lot of times, is not as bad, but if they're on high doses, if somebody's on 25 milligrams a night for sleepy, that's a lot different than 400 milligrams a day because they got schizophrenia. See what I mean? So it's a risk-benefit ratio of stopping. I agree though, reassessment, good. So reassess those medications, that's a good idea. What else? How about Albany Group 23? Go back to the problem.
Are you referring to the hypokalemia by what
Yeah. What do you want to do?
Couldn't the fludrocortisone be causing decreased potassium levels? Potentially,
but what are you going to do right now? You got to do something right now. There's no tomorrow.
Give him some potassium?
Yeah, get some potassium, baby. Right. Now, are they on potassium already? They are, right? What are they on, like 10 milliequivalents a day or something? That's nothing, man. That's homeopathic almost, okay? I'm just kidding. It's not homeopathic, but it's a low dose, okay? So give some potassium. Most institutions have electrolyte replacement protocols. In general, for every 10 milliequivalents you replace, it increases potassium 0.1 milliequivalents per liter. So if my potassium is 3.1, you give me 40 milliequivalents, I should go to 3.5. One huge caveat to that. You're really low. So if your K is less than 3, you actually need a lot more potassium to get back up to normal. What's the other thing that can cause the potassium to just stay low? Even if you just hammer them with K like over and over and over again. Mag, right? So did they have a magnesium level? Let's take a look. I bet they didn't.
They did not have a mag level.
Thank you. So they did not, right? Because most hospitals are trying to save money, and the comprehensive metabolic panel is going to be cheaper than a really comprehensive panel that includes things like phos and mag and calcium, okay? So depending on which Chem 7 or however you want to name it at your hospital, some may check mag, some may not, but typically it may not be something we go after right away, but if you're replacing their potassium and they're not budging, then consider magnesium level. Right, because this is the recipe for a big QT issue. Hypokalemia, multiple medications that they're on that definitely can prolong QT, right? Definitely we get the EKG. We've seen a number of scenarios in here, Jasleen can back me up on this, where it happens with an antibiotic, right? They're on, azithromycin or Levaquin, and they did an EKG. Day 1, and it's like 550. 677, we had one the other day, right? But nobody really went back. Why? Are they ignorant? No. These hospitalists have like 25 to 30 patients they're following. There is no way they can detail, orient, and follow everybody. They can't do it. They can't. So they're trying to get the big ticket items, fix those, get patients discharged, admit them. So don't just assume, then never assume, oh, well, the physician, no. Don't assume. Look for yourself and make. And I've used it in my own career to help get people off antibiotics. Say, oh, okay, well, you know, their QT was 677 3 days ago before Levaquin. Now I don't want to check it. I'm afraid of what I might see, right? So, problem 1, cellulitis. Agreed, we got a plan there. Problem 2, hypokalemia. I like it. Those are the 2 big ones. There's another one in there, though, I want to talk about. I don't see if anybody got it. Haven't been, let's see. Athens, how about group 10? Lucky 10. Noah, Emily, Nicholas, Matthew, and Cindy. What other problems did y'all find?
I have as a problem that Seroquel, when used in patients with dementia, increases mortality risk. Would you just discontinue the Seroquel in that case?
Oh yeah, baby. I'm glad you brought it up.
Seroquel have a big fall
It does increase mortality, doesn't it?
The patient's got a huge fall risk. And he's old. I think he's old.
Why do we do it then? Why do we do it? So, what do you think they're using the Seroquel for? Who was it? That was who answered that?
That was Noah.
Hey Noah. Noah, why do you think they're putting them on the Seroquel? Did you see any history of schizophrenia?
I didn't, but they said he showed up agitated or and confused, so they're trying to prevent hospital-acquired delirium with him, I think.
Yeah, or he's already delirious, right? And you'll see this all the time, this pre-order for Seroquel to kind of make them sleep or calm them down, quote unquote. Now, on the outpatient side, it gets used a lot, and a lot of that mortality data comes from outpatient nursing homes where they've got them on Seroquel all the time. And think about it, right? Seroquel prolongs QT, we know that. Okay? But then also, think about a nursing home patient. How nourished are they at times? Right. Dehydrated, malnourished, they're not getting any electrolytes, minerals, so they get a potassium of 2.8, nobody even knows about it. And then they're on Seroquel, and then their heart stops. They die, right? Why? Atypical antipsychotic. So I will tell you, Noah, it is a battle. Battle for the inpatients, right? Because they're like, why are we doing this to people? And it's tough. Sometimes we can get them to stop the Seroquel, but usually a problem has to happen. Like I can't just say, hey, you know this increases mortality, right? That usually doesn't go well. Okay. But we can say, hey, their potassium's this, you know, their QT is this, and a lot of times then I can potentially get them off them. So that's a great point. So in long-term patients, you got a much better argument. Short-term, it's a little bit harder to make. Good. How about, let's do group 7. What other problems did y'all have? Or did you have any?
Hypertension?
Hypertension or hypotension?
Hyper.
Hyper? All right, let me go back.
Yes.
Here. Okay. So, trying to see.
In the note it says hypo.
Yeah, he's pretty hypertensive, at least he was when he came in the door. But as an outpatient, he ran more hypotensive, right? How many blood pressure meds was he on as an outpatient? 0, right? In fact, he was on a hypertension med. Cause it. Right? So, this guy, whenever you start stacking neuromeds, which one of his neuromeds could have potentially caused some hypotension? Go back to his past medical history. Sinemet, who said it? Megan? Thank you, Megan. Sinemet, right? So dopamine agonists are classic for causing hypotension, specifically orthostatic hypotension. Orthostatic hypotension. So, but here's the problem. What are you going to do? Take away somebody's Sinemet? You can back down on the dose, but then what are you doing? You're setting that patient up for they can't move, right? So there's always this balance that they need something. Sometimes you can try a different drug class, but typically Sinemet works really well for Parkinson's disease. And so there's a balance between causing orthostasis, but at the same time allowing them to have the most benefit from the drug. Maybe this guy can't do his activities of daily living unless he gets that dose of Sinemet, right? And so they chose to treat this hypotension more with, right? What else? What are we treating it with? Fludrocortisone, right? We've seen this a few times in our hospital where they do this kind of off-label. It is listed there. So I would say, one problem, you could say hypotension, as far as, it's not a huge issue right now, but it's definitely something you're monitoring. I wouldn't call it a drug-related problem yet, but it's part of the past medical and it's definitely something you're looking at. All right, what else? About another issue.
He's not on the right Xarelto dose.
Oh, thank you. He's not, is he?
20.
All right. How many of you are calculating the creatinine clearance on every single patient? If you're not, you're in trouble. You're going to get burned, right? So every patient, you need to calculate the creatinine clearance. Who said that, by the way?
Parisa in Athens.
What group are you in?
3.
3. Parisa, okay, Parisa. So, what did you calculate as creatinine clearance as? Did you calculate one?
I got 106.
Oh, man. 106? That sounds a little high.
I think 74.
Yeah.
I didn't
So,
calculate it.
106. Here's what I know. Oh, what just happened? I just deleted everything. What y'all have?
Control X.
Control Z. Learning things.
Actually,
Look
it's
at
cut.
that. Drew. Drew. Where were you 2 weeks ago when this happened in my office? Okay. I know. Here's what I know. More than 50. More than 50. Right? Now, here's the problem. What dose was he on as an outpatient?
15.
15. 15. So, is it Parisa?
Yeah.
Okay. So, Parisa, how would you handle that with the provider? This gets a little tricky because they're on 15 at home or at the center, and now they're admitted here and they're on 15. Because I think it's an easier argument if they're on 20 at the center and now they're on 15. Now you can say, hey, this was done wrong. So what would you want to think about if they were on 15 at the center and now they're on 15 here inpatient? So I agree with you about that.
I guess I would just kind of say that
guidelines currently say 20 for the indication of AFib, so it's possible they might have thought you would have like a DVT, something along those lines.
Yeah, so it's a hard argument in the sense that you're gonna find out in y'all's career. Now, on the outpatient side, this is a lot easier to fix. Because you've got records, you've got, what happened to the patient. Like, why are they on 15? Like, that's my question is, why did they choose 15? Right? What's his indication for rivaroxaban?
Chronic AFib.
Right, chronic AFib, right? So when you look at the DOACs for AFib and renal function, all of them may or may not have a potential adjustment, right? So rivaroxaban, anything with a creatinine clearance between 15 and 50 should go to 15 milligrams a day, right? The Bigatran, Pradaxa has a lot of different recommendations. It's the most renally excreted of all the DOACs. Apixaban, of course, has the brilliant criteria that I wish I would have developed as being in Hawaii right now. Preemptively in their study, right, they had 3 criteria for a possible dose adjustment. Weight less than 60 kilos, age greater than 80, serum creatinine 1.5 or greater. If you have 2 of those 3, you get to go from 5 BID to 2.5 BID in the management of AFib, right? However, I will tell you in practice, we find a lot of wrong dose adjustments. So it is something I would definitely bring up because this person, right, what's the problem with getting 15 milligrams a day? So how about group 18 at Augusta? What's your rationale for going up to 20 milligrams a day?
That's the recommended dose.
If the dose is too low, he's at risk for a clot, so like a stroke as a result of his AFib.
Yeah, exactly, right? And how do you gauge risk of stroke in somebody with AFib?
The CHADS fast score.
Right. Did you happen to calculate one?
We got 2.
You got a 2. Okay. To be honest, I don't have it in front of me. Okay. But anybody with AFib that's anticoagulated, I would tell you do a CHADS fast calculation. Just get in the habit of it. You'll find some interesting things. You'll find people that have CHADS fast of 0 or 1. Then you got some that, the higher the number. What does that CHADS fast score really tell you? It tells you their risk of stroke over what time frame? Like over a year. Annualized stroke rate. Okay? Annualized stroke rate. So, I agree, rationale, increased risk of stroke if receiving 15 milligrams per day. Okay? I agree. So that would be something you would talk over with the hospitalist or whoever's admitted the patient. Say, hey, I know they're supposedly, because what you may find is actually that was entered into the med rec wrong. It wasn't 15, it was actually 20. Somebody hit the wrong drop down button. Oops. Right? Don't assume. Don't assume that they did the right thing, okay? I don't want to make y'all not trust anybody. That's not what I'm here to do. But trust and verify. Trust and verify. So 15 milligrams a day is definitely too low for him. Sometimes you'll hear things like, oh, well, he had a bad GI bleed a month ago, 6 months ago. We just decided, quote unquote, to do 15 milligrams a day. But you want to verify that, because otherwise, if I'm Dewey, Cheatham, and Howell, the law firm, okay? Do I Cheatham? Never mind. All right, so when you do that, right, and they're on 15 milligrams a day and they have a stroke and their creatinine clearance is above 50, who's getting sued? That provider, okay? So, you got strong evidence to stand on. What are you going to monitor? How about, let's see, group 8. What do you want to monitor?
Signs and symptoms of bleeding.
Good. Okay. Group 4, anything else?
I have a question about, I know it's an anticoagulant, but the patient's platelets are 74,000, so how do you assess that?
Yeah. I don't know. I don't know what to do with that. 74,000, huh? That's pretty low. So maybe that's why they're doing 15.
Isn't there also an interaction with amiodarone?
With the amio, potentially, is there a dose adjustment recommended for amio and Xarelto?
There isn't. It just says that the Xarelto concentration may be increased by the amiodarone.
Right. So, this is where you got to get clarification. And that's the whole point of this case, is that something on the surface looks very black and white, i.e. creatinine clearance is above 50, they should be getting 20 milligrams a day. But as Summer said, platelet count is low, thrombocytopenia, they're also on amiodarone, which may increase concentrations a little bit. Maybe the decision has been made, we're going to go with 15. But that's where you would want to dig into that a little bit more before you just go and change it. Okay, but I will tell you, I mean, still based on an anticoagulation basis, should be on 20. Okay, but that would be a decision you have to check. Okay. So go ahead. What were you saying about the? Was it group 4 I was asking?
Yeah, that's right. We said like you usually just get this at baseline and monitor it regularly, but like you want to keep an eye out on like renal function, because in the future like if he's in the hospital, because that way you can look at possible reductions in dose if needed.
Okay. Renal function, I agree. Good.
And also we have a CBC at baseline already. We would also watch that as well.
Yeah. Good. So CBC, right? Go over here. Yeah, baby. 74,000 is terrible. All right. He's a bleed risk, right? So my hunch is that's why the decision was made. It's because of it. What's the problem with that assessment, right? I bet if you go back to the Xarelto trial for AFib, that was a contraindication to therapy. Meaning that they excluded people with a platelet count below a certain number out of the trial. They just weren't even included. So then that brings up the point, is this person even a Xarelto candidate, period? Should they be on something we can monitor a little bit better? Like Coumadin, right? So, yeah, great points. The other things you would think about monitoring, these are all kind of toxicity, right? From an effectiveness standpoint, really what I would say is, stroke symptoms, but also don't forget about TIAs. So I had a classic case years ago of a patient on Pradaxa, which is twice a day. Anybody know the primary side effect of Pradaxa? Dyspepsia, okay? So she told me, she's like, oh, my dyspepsia is better because I stopped sleeping nightly. And she was waking up every morning with TIA and stroke symptoms. We're like, okay, that's not normal. Let's fix that and get you on something else that doesn't cause dyspepsia. So, again, going back to not assuming. Okay? So, major problems, I would say, cellulitis, abscess, etc. And then the hypokalemia with all the QT prolonging meds they're on, and potential risk for an arrhythmia. And then also with their AFib, just kind of working through that with the amiodarone, the Xarelto discussion as far as renal dose, they are thrombocytopenic, that's going to be an issue. Other problems, these aren't necessarily drug-related problems, but things you're going to be, they definitely have dementia, Parkinson's disease, all those meds are on. There's not necessarily a problem that I saw with them, but they are things that you're going to be monitoring as well.
You get the gist.
All right, so let's do a case follow-up here.
No.
See if this thing works here. Maybe. No, I'll put it on the screen a different way. Oh, yeah, right here. Okay, sorry. Awkward. But, here we go. So Mr. Lawrence on hospital day 4 is ready for discharge for treatment of his cellulitis, primary problem. What are some options for discharge antibiotics and how he's determined which agents to use for him? Also, sorry, it doesn't say, could this whole admission have been avoided or at least shortened? How so? So take a few minutes to kind of work through that in your mind, and then we'll have a discussion among the groups. You can talk to your groups for a minute if you like, and then we'll talk about, what are you going to send them home on, if anything? What are the things you want to work through to kind of come up with that solution? And then the other part is, could we have avoided this period, this whole admission? Okay? So I'll give you a few minutes there to work on that. I'll be right back.
No, across the board, everywhere, 58% of candidates did not match for phase one. No, it's like, it's
Well, not, I don't think it's 100. It's just about where you match.
It's a 50% mismatch.
I do kind of feel bad asking my sister, but I think Cassie would be fine. We can't. I don't think. I would just tell her, like, just be like, oh, I was planning on sleeping on the couch and she was going to sleep in her sister's boat for 30 years. And then you and her, yeah.
That's what it says that morning.
Ew.
There was a med student who posted on her Instagram.
How many rotations do we have this semester? 3?
2 in the summer.
2 in the year. How many credits?
5.
Huh?
5 rotations.
So that's 10. Like, how much a credit hour each year?
Between 7 and 8 grand.
For summer? Okay. Is that including fees and everything, or
I
just?
think so.
Okay.
I don't know about that.
Oh, I have to ask for more money.
Yeah, I did
I took it
that.
out every 3 grand a year, so I wouldn't have to amend my financial aid.
I just updated mine, like over
Okay.
break. I asked for more money. I was like, I need this for this money.
Oh. Always more money.
I always get, like, emails from Cornerstone Road, and I don't really look at it twice because I just don't want to look at it.
It's depressing.
I don't know
I
if they, like,
used to
said
like
anything
open it
important.
all the time, and then like I noticed that the interest rate just like kept going up, so then I stopped checking it because I was like, this is making me sad. I was like, I want to be poor.
Add to the depression of the day.
Can you get my loans through?
Class over?
I don't think so. Nope. He said something about talking about this with our group.
And get back, so hospital day 4 is ready for discharge. What are some options, okay? Someone give me an option that they chose and kind of give me your rationale for why and how you're gonna monitor it.
So I wanted to put the patient on Vectrum actually from the beginning because he has a pretty mild infection, he doesn't even have a fever. And we could have let him go on PO Vectrum back to a healthcare facility where he could be monitored, and if he did get a fever or if he got any worse, you know, it would not have been hard to get him back into the hospital.
Okay, yeah, so you were thinking, man, like as soon as you got that culture back, you would have probably de-escalated him.
Yes, sir.
Yeah, I think that's reasonable. You know, I will tell you in general, we treat cellulitis for way too long. Now, to be clear, I keep saying cellulitis, okay? Under the FDA's umbrella, there are 3 things that are called an acute bacterial skin and skin structure infection under that window. Number 1 is a wound infection. Number 2 is cellulitis. And number 3 is an abscess. So because this guy has MRSA growing, this is from an abscess. So I apologize if I confused people, okay? For cellulitis, where it's just a red, hot, warm area, we don't get a culture on that. Otherwise, you'd have to do what's called a punch biopsy, where they essentially, you know, take a piece of that skin out. And let me tell you, no one agrees to that, okay? But if it's an abscess with pus, we drain it, culture it, and that's what was here, okay? So you like the idea of Bactrim? What would you be, how long would you give it Bactrim for? What would you monitor? Give me a little bit more info.
Sure, he can have one double-strength tablet around twice a day for 5 days. I know normally Bactrim, we can be concerned about it in our elderly patients, but his renal function is pretty good. And he actually has a low potassium, so I'm not so worried about hyperkalemia.
The music to my ears. Do you hear the synthesis of info? It's beautiful, okay? Right, I agree. They got room on their potassium. It's low already. You know, the data for 2 double-strength tablets twice a day is not super better than 1 double-strength twice a day. You know, the biggest thing you want to make sure is they don't have an allergy to sulfa drugs. Make sure you don't put them on a sulfa drug when they have a sulfa allergy. Yeah, I like it. And you know, potassium, what else are you monitoring for? What do you always want to tell patients to monitor for? Rash, right? Any sort of rash that appears, they need to know about it. And obviously this guy's at a healthcare facility, so he's going to know about that, or he's going to have people watching him. But yeah, Bactrim I think would be fine, 5 to 7 days, I agree. Short course, probably a week or less. 5 to 7 days is a good idea. Any other options besides Bactrim?
You could do doxycycline 100 milligrams twice a day for 7 days.
Awesome. All right. So why did you choose Doxy?
It covers MRSA and it's
You're leaving me hanging.
it's recommended in the guidelines.
Okay. Good. So let me pull up something here.
Dr. Blaine, we also discussed that it protects from C. diff, but it also can be open, like it has open in case you can't swallow the Bactrim.
Okay. Got it. Okay, cool. So let me pull up the report here. Okay. So, yeah, Doxy, so if you can't swallow, right, Doxy's going to have a risk of pill esophagitis, GI intolerance, definitely. Bactrim does have a liquid, so that is one option. If they can swallow a liquid, you could do like PEDS, you know, what we get for kids for skin soft tissue infections. But yeah, Doxy, I love doxycycline. The CDC did this contest every year, and it's like, what drug are you? And you fill out all the information. I was Doxy, I guess. I don't know what that means. I call it dyspepsia. But anyway, one of the nice things is it is neutral against C. diff at a minimum, but probably protective. So with that, if Lawrence had just got, if he had just had C. diff 2 months ago, and now he's in here for this, I think Doxy would definitely be the right option. Bactrim's not a wrong option either. Either one of those options, I think, would be perfectly fine. The one option I didn't want people to say was Clinton. Okay, it's got a big R beside it, right? So, you know, anytime you're doing a culture and susceptibility interpretation, you want to look at that. So, I think either one of those would be fine. You know, if he's in the hospital and he did have a fever, he had a leukocytosis, one question that was brought up was, his white count's kind of low. Y'all notice that? So you will find that, I mean, all his cell lines are pretty low, which is kind of concerning that there could be some other underlying problem that has not been diagnosed. You know, what if this guy had a 30-pound weight loss in the last 6 months, unintentional, and all of his cell lines are down? Alcohol abuse can definitely decrease all your cell lines. That's a known fact. African Americans can sometimes just have low white counts at baseline, like 2,000-3,000. Not necessarily neutropenic, but lower than the normal range that you see. So, but cellulitis or abscess in general does not necessarily make you have a leukocytosis. You don't necessarily come in with a high white count. Okay. So, yep, so he's got MRSA. You know, I think Doxy would be fine. Trimsulfa would be fine. What about linezolid? I mean, this guy got admitted to the hospital for an MRSA abscess. I mean, linezolid's not printed there, but would you expect linezolid to work? Yeah. So what's wrong with linezolid? Okay, go ahead. Sorry, man.
Side effects?
Yeah, side effects, right? So what are the potential drug interactions, right? He's on Lexapro, okay? So he's on Lexapro, right? And linezolid at baseline is a weak MAO inhibitor. So that's not going to be a good option, right? Especially when you've got other options. Now sometimes you're forced into linezolid, and that's fine. We monitor for that. But what else is the problem with linezolid on that? What would be be another really good reason not to use it on him? Yeah, say it. Not yet.
Decreased platelets?
Yeah, good job, Ashley. So thrombocytopenia, and he's on Lexapro. That's two good reasons not to use the drug. Okay? This is what is so great about ID, right? You got multiple different ways to help the patient. All right, so let's go to the second part of our question. The other part of it was tolerating oral. So is this a guy that if he's tolerating PO, is he swallowing okay? Is he eating? Is he following commands? Is he able to do the oral therapy that you want to put him on? Right? Because I can tell you at these nursing homes and kind of long-term care facilities, they may or may not do a ton of IV meds depending on their nursing staff and what their protocols are. Okay? All right, good deal. Poor Drew, man, he's got like horrible bronchitis over here. Adenovirus just smacking you around. He's all right. All right. So, how could this whole admission be avoided or at least shortened, and how so? Could we have avoided the admission at all? So it sounded like one group was like, this is pretty mild abscess, but they needed incision and drainage, right, for the abscess. You could do that as an outpatient or in the ED. What's a potential option for him? I wish the other campuses could see here in Savannah. They're like looking at me like, I don't know. It's Monday after spring break. Please take for me. Okay. So take a guess. Obviously, if I'm asking you the question, the answer is yes. Okay, it could have been avoided. But what could we do? Any campus. No ideas. I know we talked about this. Come on, Summer, pull the trigger. I see your hand, like itchy trigger finger over there. What if I told you that there was an antibiotic that is great for skin soft tissue infections that has a half-life of like 300 hours?
Dalbavancin.
Yeah, so say it. Yeah, so a long-acting lipoglycopeptide, right? So the idea behind the long-acting lipoglycopeptides, right? So an example of this would be dalbavancin or oritavancin. These are long-acting lipoglycopeptides that are one dose and done. So I think this would set up nicely, and actually this patient, what ended up happening, he was a little, like his mental status was just not quite, I mean, look how many neuro drugs he was on. Lexapro, Trazodone, Seroquel, like he was just kind of fuzzy the whole time he was here, and we were concerned that even if we discharged him on oral meds, he may or may not finish the course, quite honestly. So the decision was made, instead of keeping him at our facility for, to finish his vancomycin therapy up, we actually did an early discharge protocol where we put him on a one-time dose of dalbavancin, and we're able to discharge him right after. It's a 30-minute infusion, and it's good for essentially in the body. You can find bone and joint concentrations for like months afterwards, which is not good. I wish that wasn't the case. But this is a way, and this is really changing how we practice, is that there are a number of patients that have cellulitis, have abscess, and in reality, that's the only reason they're getting admitted. It's not like they've got all these other factors going on. And it's just easier to put them on that and avoid an admission or shorten their overall course, okay? So I'll show you an article that kind of talks about this. Maybe. Let's see. So this was actually being done here at Candler by Bruce, my partner here, in infectious disease. So this was an article where we looked at how can we, because it was pretty horrible what we figured out was that our length of stay for cellulitis was 3 or 4 days past the national average. That's horrific, because guess what? In the payment world, you don't get paid for those extra days they stay here. You are losing money left and right. So what we were able to show is by instituting, we worked directly with our hospitalists and our case managers to figure out who are good candidates for this, not septic, not septic shock, ICU, but sick enough to where they probably need IV antibiotics, but maybe not somebody you could put on oral Bactrim right offhand. We were able to show a decrease in length of stay compared to our previous numbers, essentially 8 days versus 4.3. So we were able to shorten the length of stay for our patients and get them out quicker. Why didn't we just do this in the ER? We get asked that question a lot. Why do you think this is a hard thing to pull off in the emergency room to just totally prevent the ignition? Any thoughts? Other campuses? Athens? Albany, Augusta? What would make this hard to really do in the ER?
Availability and cost.
Exactly. This infusion cost, I think, about $3,000. Now, if you can prevent a hospitalization or shorten length of stay, that's cost effective. But here's the problem. Getting that approval in an emergency room in a timely fashion is really hard to pull off. So in reality, we went more towards shortening the course of stay as opposed to getting it approved on the front end to decrease, to stop their admissions. A few centers have been able to successfully do this, but if you're at a VA or a DOD where all the, there's no approval process other than people talking, there's not some huge red tape or insurance issue, this actually can work really well. Or a Kaiser Permanente, like it's in Atlanta or Colorado, where everybody's kind of in the same system and everybody's talking, you can get this done in a timely manner, this would be appropriate. But for third-party insurance, it's kind of hard to pull off, honestly. So this allows us some time to be able to do that and to be able to discharge patients early in an appropriate fashion. So we were able to shorten their length of stay. This particular patient, we did a quality of life assessment, called them back, see how they were doing, and worked out really well. So that's going to be the future. Is instead of admitting all these patients, because the last place you want to be is a hospital. Something can go wrong, right? And you get the wrong med, you get the wrong dose, you get a central line infection, you get a UTI, something like that. And so if we can prevent patients from coming in or early discharge them back to where they were from. I mean, this guy, you can imagine these elderly patients, when they come into the hospital, their sleep cycle gets off way big time. They get ICU delirium. They don't know night from day. They get confused. They start throwing punches at people. I mean, it's truly a real problem. So getting them off of their schedule when they have dementia. This person had aggressive behavior, right? That was one thing we need to talk about. They were going to keep them on their Depakote, right, for their aggressive behavior. And so all those factors come into play. You do not want this guy to be in the hospital for a long period of time. So those were the major issues I had. Are there any questions? I'll do it by campus. Any questions from the Albany campus?
No, sir.
You made it. Okay. How about the Augusta campus?
No, sir, we're good.
All right. And Athens?
No questions.
Okay. Any questions here? We good? All right, if you have questions or, about the case and listen, this is the third year I've done this case. If you see things that you think should be corrected or things that were confusing, you are not hurting my feelings by sending that to me via email. I want to make it better, okay? So send it to me. I'll be glad to look at that. Chances are it'll make the case better for the next year. These are always being looked at, modified, and changed. So, okay? All right. Thank you.